Now, few things about chest X-rays. Tracheal displacement. No patient rotation. The spinous process are central between the medial clavicles. The spinous process is red line are central between the medial clavicles, that is blue lines. Trachea, that is asterisk, shifted to the left of the midline. Soft tissue mass mainly to the right of the trachea. Diagnosis is mediastinal thyroid enlargement. Tracheal displacement seen on CT, trachea asterisk, shifted to the left of the midline or red line. Soft tissue mass on the right side of the trachea, highlighted area. The CT finding correlate well with the X-ray. Diagnosis is mediastinal thyroid enlargement causing tracheal deviation. Bilateral hilar enlargement. Both hilar are larger and denser than normal. Clinically patient presents with joint pain, erythema nodosum. So this diagnosis is sarcoidosis. What are the differential? Lymphoma, metastatic disease, or infection may occasionally look similar. Pulmonary arterial hypertension may also cause bilateral symmetrical hilar enlargement. Now, asymmetric hilar enlargement, both hilar are larger and denser than normal. The right hilum is bigger than the left. Multiple small lung nodules, missing right breast shadow. So mastectomy is done here. So clinical information in this case is known breast cancer, increasing shortness of breath. Diagnosis is metastatic disease, breast cancer. Now, abnormal hilar position. The left hilum is large, dense, and pulled laterally and upwards to the left. The trachea is deviated towards the left, indicating the loss of lung volume in the left hemithorax. Clinical details: history of left hilar malignancy treated with radiotherapy. And diagnosis is radiation fibrosis. Consolidation with air bronchogram. The left middle zone is white. Dark lines through the area of the white are a good example of air bronchogram. The patient had a high temperature and a productive cough. Diagnosis is pneumonia, consolidation with pus. Differential diagnosis of consolidation: pneumonia always full of pus, cancer always full of cells, pulmonary hemorrhage always full of blood, and pulmonary edema always full of fluid. Unilateral middle zone abnormality. The middle zones are asymmetrical. There is a small irregular opacity on the right. This opacity contains a dark area cavity. Other areas of the lungs are normal. Clinical information: this patient had a history of intravenous drug abuse and presented with high fever. So diagnosis: septic embolus. Differential diagnosis of lung cavities is lung abscesses, TB, Klebsiella, or Staph aureus, lung cancer, septic embolus, infected thrombus, fungal infection if immunocompromised, granulomatosis with polyangiitis. This is bilateral abnormal lung zones. Bilateral abnormal lung zones, multiple bilateral lung nodules, symmetrical distribution, more nodules at the lung bases. Clinical information: shortness of breath, weight loss, and clinically suspected underlying malignancy. Diagnosis is pulmonary metastasis. Now this is the unilateral black lower zone, asymmetrical lower zones, left darker than the right, and lung hyperexpansion. Clinical information: chronic smoker with increasing shortness of breath. The diagnosis is chronic obstructive pulmonary disease with a large left lower zone lung bulla. Now, pleural disease and pneumothorax. Pneumothorax, visible pleural edge, that is blue line, lung marking not visible beyond the edge. Clinical information: this is due to fall from the height, trauma to the chest. Diagnosis: left pneumothorax due to a rib fracture, that is the arrowhead, and the trachea and mediastinal structures are not displaced, so there is no tension. Unilateral pleural thickening, lobulated peripheral shadowing on the right, loss of right lung volume, shadowing over the whole right lung due to circumferential pleural thickening. Clinical information: shortness of breath and right side chest pain, history of asbestos exposure. Diagnosis is biopsy results showed this to be a mesothelioma, a malignancy of the pleura caused by exposure to the asbestos. Asbestos-related pleural plaques, bilateral well-defined irregular shadows that are as dense as bones, peripheral pleural thickening. Clinical information: chronic mild shortness of breath, retired dock worker with history of multiple exposure to asbestos. Diagnosis: bilateral calcified asbestos-related pleural plaques. Pleural effusion: the left lower zone is uniformly white, at the top of which white area there is a concave surface, meniscus sign. The left heart border, costophrenic angle, and hemidiaphragm are obscured. Slight blunting of the right costophrenic angle indicates a small pleural effusion on that side. Clinical information: lifelong smoker, weight loss and increasing softness of breath. Diagnosis: large left pleural effusion, underlying bronchitic carcinoma. This is right middle lobe consolidation, the right heart border, right atrial edge is obscured, consolidation is limited above by a crisp line formed by the horizontal fissure. The pathology must therefore involve the right middle lobe. More extensive shadowing also involves the right and left peripheral regions. Clinical information: child with a cough and fever, diagnosis pneumonia involving the right middle lobe. Right upper lobe collapse. The horizontal fissure has been displaced upwards from its original position, that is red line. Dense opacification of the middle part of the right upper zone, large right hilum. And clinical information: smoker, progressive shortness of breath and cough. Diagnosis: right upper lobe collapse. Other investigation: bronchoscopy revealed a lung cancer causing obstruction to the right upper lobe bronchus. Left lower lobe cavity frontal view, large round thick walled lung cavity. This cavity is in the left middle zone close to the hilum. Which lobe do you think it is in? This is left lower lobe cavity lateral view. Left lower lobe cavity lateral view. The cavity is behind the oblique fissure, blue line, and so must be in the lower lobe. Clinical information: long-term smoker with a cough. Diagnosis is left lower lobe lung cavity, in this case due to a squamous cell lung cancer. Right costophrenic angle blunting. The left costophrenic angle sharply defined, that is normal. The right costophrenic angle is blunt, that is abnormal. There is volume loss in the right hemithorax with corresponding shift of the mediastinum and trachea to the right, that is the aorus. Note this: the pleural effusions do not cause volume loss. Clinical information: chronic smoker, chronic shortness of breath with recent worsening. Diagnosis: lung cancer occluding the central airways with collapse of the right, middle, and lower lobes, and confirmed by CT and bronchoscopy. Lung hyperexpansion: both costophrenic angles are blunt due to lung hyperextension. The hemidiaphragms are flattened, indicating hyperextension. The lung markings are distorted bilaterally. Clinical information: occasional and past smoker, chronic liver disease. Diagnosis: chronic obstructive pulmonary disease, COPD, underlying alpha-1 antitrypsin deficiency. Pneumoperitoneum on the erect chest X-ray. The lungs are normal. The diaphragm is crispy, defined on both sides. Arrowheads, air under the diaphragm asterisk is seen as crescents of relatively low density, that is black. Black air can be seen on both sides of the bowel wall, blue line. This is known as the double sign or regular sign, usually only seen on the abdominal X-ray. Clinical information on acute severe abdominal pain, abdominal guarding on examination. Risk factors for peptic ulcers include smoking, high alcohol intake, and long-term use of non-steroidal anti-inflammatory drugs. Diagnosis: pneumoperitoneum at laparotomy, perforated duodenal ulcer was found. Left lower lobe consolidation. The left hemidiaphragm is obscured. Left line is normal position. Consolidation of the left lung base extends behind the heart. Clinical information: cough, high temperature, and raised white cell count. Diagnosis: left lower lobe pneumonia. Diaphragmatic rupture. The left hemidiaphragm is not visible. There is bowel in the left lower half of the left hemithorax. The mediastinum is displaced to the right. Clinical information: history of severe chest trauma. Diagnosis: left hemidiaphragmatic rupture with the herniation of bowel into the left hemithorax. Frenulum palsy, raised left hemidiaphragm, left upper zone mass contracts the mediastinum. Clinical information: known inoperable lung cancer, rapid worsening of the shortness of breath. Diagnosis: left frenulum palsy due to direct invasion of the nerve. Caution: occasionally a raised hemidiaphragm may be mistaken for a pleural effusion. They can have similar appearance and both can cause dilatation to the percussion, but only an effusion should be drained. A CT may be necessary prior to chest drain insertion if there is any doubt. Signs of heart failure: cardiomegaly, CT or 18/30, upper zone vessel enlargement, sign of pulmonary venous hyperextension, septal lines, that is Carly B lines, a sign of interstitial edema, airspace shadowing due to alveolar edema acutely in the perihilar or the bat swing distribution, blunt costophrenic angle due to pleural effusion. Clinical information: worsening exercise tolerance, chronic uncontrolled hypertension, and rapid onset of shortness of breath, atrial fibrillation. Diagnosis: left ventricular failure with pulmonary edema. Now septal line or curly B line. Septal line, costophrenic angle, details of the above image. Horizontal lines reaching lung age. Diagnosis: septal lines are a specific sign of interstitial edema in the context of suspected heart failure. Differential diagnosis: there is no clinical suspicion of the heart failure, then conditions that cause lymphatic obstruction such as sarcoidosis or lymphangitis carcinomatosa should be considered a possible cause of septal lines. Alveolar edema, airspace shadowing. Dense airspace shadowing is due to alveolar edema caused by fluid filling of the alveoli and small airways. In the acute setting of the airspace shadowing, radiates from the higher regions in the bad swelling distribution and then becomes more generalized. Heart chamber enlargement, left atrial enlargement. The left and right heart borders are marked, then extra right heart border formed by the edge of the enlarged left atrium that is highlighted in area, slight bulge in the left heart border due to enlargement of the left atrial appendages. Splaying of the carina to greater than 90 degrees, the carina lies directly above the left atrium. Clinical information: history of rheumatic heart disease and cardiac surgery. Note the metallic aortic and mitral heart valve replacement, arrowhead. And diagnosis: cardiomegaly with left atrial enlargement due to chronic mixed mitral heart disease. Left ventricular aneurysm, epi-rec chest X-ray, bulging of the left heart border, circular ring of calcification. Clinical information: previous myocardial infarction. Left ventricular aneurysm, an uncommon complication of the myocardial infarction. And this is left ventricular aneurysm. And consolidation of the lingula, poorly defined left heart border due to consolidation in the adjacent lingula. Clinical information: reductive cough, raised white count. Diagnosis: lobar pneumonia. Mediastinal mass, wide upper mediastinum, arrowheads, poorly defined outer knuckle, indicating adjacent disease, wide right patriarchal space at streaks. Clinical information: night sweats and weight loss, palpable neck lymph node, and diagnosis: Hodgkin's lymphoma. Mediastinal mass, lateral view, same patient as image above. Mass located in the anteromediastinal anterior to the heart. Diagnosis is Hodgkin's lymphoma. Differential diagnosis of the anteromediastinal mass: lymphoma, thyroid enlargement, teratoma, tumor of the thymus. Thoracic aortic aneurysm, sternal wires and aortic valve processes, arrowhead. Massive aortic knuckle is a red line, displaced tracheal arrow, and widened tortuous descending aorta. Clinical information: history of the uncontrolled hypertension, previous history of the severe chest pain radiating to the neck and back, chronic thoracic aortic aneurysm treated with surgical repair of the aortic root. Mastectomy, increased density over the right lungs, decreased density of the left lung, breast asymmetry. Clinical information: diagnosis: previous breast cancer of the left breast treated by the mastectomy. Do not mistake soft tissue asymmetry for lung disease. Gynecomastia, mobile epi-sitting, chest X-ray, cardiac monitoring leads, and dense breast tissue, male patients. So patient on the spinal lactone, diagnosis: gynecomastia or male breast enlargement. Surgical emphysema, epi-rec chest X-ray, left chest drain, orange, raised left hemidiaphragm, stomach or bowel bubble, that is asterisk, multiple irregular areas of low density within the chest wall, soft tissue, multiple rib fractures. Clinical information: road traffic crash, chest pain, shortness of breath, and marked clinical surgical emphysema. Diagnosis is multiple rib fractures complicated by left hemidiaphragm injury, left pneumothorax, and widespread surgical emphysema. Multiple acute rib fractures, blunt trauma to chest wall, mobile supine chest X-ray, multiple fractures of fourth, right rib, and other visible fractures of third, fifth, sixth, and seventh right ribs, arrowheads, raised right hemidiaphragm due to reduced ventilation secondary to pain, and increased density of the right lower zone due to lung continuous, and generalized increased density of the right likely due to hemothorax. Old rib fractures, there is angulation of the ribs at multiple fracture sites. At the site of the injuries, there is increased density due to callus formation. Malignant bone disease, pacemaker, dense or sclerotic ribs, arrowheads, patchy dense or sclerotic clavicles, and humerine. Asterisk, bilateral lower zone consolidation with a pleural effusion on the right, no pathological fracture seen. Clinical information: known prostate cancer, cough and fever, diagnosis pneumonia with associated diffusion with static bone disease. Thank you.